Welcome everyone to the IARP conference session titled Telehealth, New Considerations for Life Care Planners. I am Laura Woodard, your session host for today's session. I know everyone knows the drill by now, but please put your questions in the Q&A and I'll be monitoring those. I will also try to keep an eye on the chat, but use the Q&A if you can. This session is going to be broken up into two different parts. Lisa Gay and Carol Fricks will be going for the first half, and they asked that questions be held until the end of their presentation. So I will be taking questions at the end, and then their section will be followed by Mary Barros Bailey, and I'll be taking some questions throughout her session. So just to introduce our wonderful speakers, Carol Fricks has been a registered nurse since 1984 and became a certified life care planner in 2003. In 2019, she was elected to be a member at large on the board of directors for the International Academy of Life Care Planning section of IARP. Lisa Gay has been working with patients of all ages as a family nurse practitioner for over 10 years and was awarded the American Academy of Nurse Practitioners State Award for Excellence in 2018 for the US Virgin Islands. She is a certified life care planner with experience in a variety of pediatric and adult cases. Mary Barros Bailey is a multilingual Portuguese, English, Spanish rehabilitation counselor, vocational expert, and life care planner in private practice with Intermountain Vocational Services in Boise, Idaho, with a national and international caseload. So thank you all for agreeing to present today, and I'm going to turn the floor over to you.
Thank you, Laura. Let me just get slides up here. Oh, I went ahead one. All right, so as Laura said, my name is Lisa Gay, and we are going to be talking about telehealth today, both the history of telehealth as it relates to life care planning and sort of the changes that have happened recently with COVID-19. These are our learning outcomes, and while these are up on the screen, I think we're going to do a quick poll. So hold on a sec. So I can't see the Zoom. Carol, can you see it?
No, I can't see the poll.
Ayudayo?
There it is.
There we go.
Got it.
So we were just curious how many of you out there currently include telehealth options in your life care plans. And we'll give you a few moments here to do that. Looks like, let's see.
100% have answered, so.
Okay, so that's a 50-50. That's
interesting.
Yeah. All right. So let me take that down and keep going. All right, so a little bit of history with telehealth. Obviously, telehealth has changed a lot in just the last year and a half, but we consider telephone as part of telehealth. So the first reference that's known for telehealth is back in 1879. There was an article in The Lancet that discussed the potential of telephone to reduce the necessity of in-person visits. Moving on in 1925, an article in Science and Invention showed a doctor diagnosing a patient by radio communication. But really, telehealth as we know it now, a lot of it was developed by NASA for their astronauts. They wanted technology that could enable their astronauts to receive care while they were in space. So they started with test flights with animals attached to medical monitoring systems and continued on to having their astronauts be able to be remotely monitored while they're in space. They've also collaborated a lot with other countries, and that has enabled some providing of telehealth services to other countries following natural disasters, even well before telehealth was being used in medical offices. So they continue to develop remote care options and really further the science with that. And then in 2019, there was a Fair Health white paper talking about alternative care modalities that showed that there was a national utilization of telehealth services increased by 53% between 2016 and 2017. So it was catching on. We were getting there before COVID came along, but then fast forward to the beginning of 2020 and everything changed. So the onset of COVID-19 and the Department of Health and Human Services estimates that about April of 2020, 43.5% of Medicare primary care visits were provided via telehealth. That's up from 0.1% of Medicare primary care visits prior to the pandemic. And we're going to get into some of the regulations that CMS has set around telehealth visits prior to the pandemic that really was limiting for that. The utilization of telehealth has gone up and down over the last year and a half. Really boomed in the beginning and then went down. And as there have been more waves, there haven't necessarily been more surges in the use of telehealth. They said that in July of 2021, utilization had stabilized at about 38 times higher than pre-pandemic use. And it ranged from 13 to 17% of visits across all specialties. So obviously, the things that changed with COVID-19, suddenly there was an increased consumer willingness and provider willingness to use telehealth. I know in my own personal experience, we had a really hard time getting patients to agree to telehealth visits prior to the COVID-19 pandemic. And then suddenly when we were all more afraid of COVID than we were of either the technology or the potential changes in care, then we were willing to give it a try. And once people have tried it, most of them are willing to give it more shots. And then of course, regulatory changes, which I'm going to get into. You can see on the right side of this slide, for me personally, and I think for a lot of people, one of the biggest regulatory changes was the ability to use, the official wording is any non-public facing audio or video communication. So what they mean by that is that we can use anything that's private. FaceTime, Facebook Messenger, Google Hangouts, WhatsApp, Zoom, Skype, any of those are available to us, and we're not regulated by HIPAA compliance anymore, for better or worse. But when it comes to ease of use, that's definitely for the better. What they mean by public facing products, so what's excluded are the things you really wouldn't want your telehealth visits to be by anyway. TikTok, Facebook Live, Twitch, public chat rooms. So anything that is just a blatant HIPAA violation. So for me personally, in my primary care practice, we were, prior to the pandemic, trying to use our EMR software for telehealth visits. It allowed us to kind of do a little bit of the visit and the documentation at the same time, but it was very prohibitive for some of our patients. Our elderly patients especially needed a computer. They needed to go in and log in and register ahead of time. The EMR needed to be functioning correctly. And from a costing standpoint for our office, we were being charged a flat fee for every single visit. So to be able to meet the patient wherever they are, so basically we can say ahead of time, what do you already use? Do you use FaceTime? Do you use WhatsApp? And we can, the day before, make sure we have the same software installed. We're able to send a link or make a call that way. And it's just really made it so much more accessible. Recently, in August of 2021, they made a ruling that they will continue to allow that type of communication for 7 years after the last day of the public health emergency. So we should have at least another 7 years of that and time within there to figure it out, how to keep it that way, or at least make those platforms more HIPAA compliant. Another big change is the ability to use telehealth services across state lines. This is state by state. So it really depends on the state. There is a link here. Of course, you've got these by PDF, so you would have to type it in. But previously, we couldn't provide telehealth in any state where we weren't licensed, and that included our own patients being in another state on vacation. Certainly we could talk to them by phone and consult with them, but we couldn't bill for those services. And now we've got a lot more freedoms there. Pretty much every state requires that you apply for a temporary allowance. You can't just start providing care, but the big hoops that had to be jumped through before, a lot of those have come down. You can view those regulations state by state because they are changing quite frequently. And then prior to the pandemic, CMS, the Centers for Medicare and Medicaid Services, had a lot of very restrictive policies surrounding telehealth. The one that I found the most interesting was that they couldn't initiate a telehealth visit from within the patient's home. So telehealth wasn't thought of as something where you could see your primary care provider that way. It was really for patients to come in to a provider's office and have access to a specialty provider from within their provider's office. So while that's extremely helpful for some people, it was also very limiting in a lot of ways. We weren't allowed to bill for telephone consultations necessarily. There were a lot of rules that came around that. We weren't allowed to see a patient for the first time via telehealth. And there were a lot of provider types that weren't recognized to use telehealth, such as physical therapists. So right now, all of those regulations have come down. There have been changes with all of them, and we don't know yet. They haven't said yet what the future will hold in terms of those regulations. So we'll just wait and see.
Thank you, Lisa. So who's using telehealth? Really just about everyone. Primary care providers, behavioral and mental health clinicians, endocrinologists, gastroenterologists. Now, if you have a pediatric case, obviously, if you need a G-tube change or replacement, that needs to be in the clinic visit. Pain management, again, you can do diagnoses through telehealth and pain management, but you may have to come into the clinic for injection or a block or a procedure. Cardiology, neurology, therapeutic interventions, and case management can very effectively be done through telehealth and telemedicine. Next slide. So who can benefit the most from telehealth services? People who are immunocompromised or are highly susceptible to the complications of COVID, COPD patients, people on oxygen, or individuals with autoimmune disorders. They can effectively be seen through telehealth visits. Rural residents. So I use an example. I have a lot of cases in Oregon, and the children live in rural areas, and it may be a 3 or 4 hour drive up to their primary specialists up in Portland at Shriners Hospital. Telehealth visits for routine management or follow-up can be very effective. And obviously, you're going to need the in-clinic visits for like wheelchair assessments and things like that. However, having that follow-up care for your pediatric cases or your elderly cases is very, very effective. And it also reduces the parental guilt of the parent that's taking the child that 3 hours away, and then they're gone all day and they're maybe leaving other children. Also, somebody that has numerous annual provider visits, somebody that needs monthly management or monitoring of blood pressure, glucose, diabetes, things like that, they can benefit. Also, people that have problems with adherence to the follow-up recommendations, they can benefit. And then transportation is a big issue. I have a case now in Illinois, and this woman received her definitive prosthetic leg back in May. And her prosthetist is saying that in order for her to get training on the leg, she needs to go see her primary care physician in order to get the prescription for the physical therapy so she can get the training on her prosthetic leg. And she has not been able to access or afford any kind of transportation to get into her primary care physician. So, a telehealth visit potentially would mitigate that. And then, again, the long distance from their specialists or the providers, the telemedicine offers that option. And then people with chronic conditions and acute illnesses. Now, there are barriers to telehealth, and that includes people that a remote visit is just not a right fit for them, or they have difficulty accessing technology, or they don't have high-speed internet. My dad would have an extremely difficult time at 90-year-old with accessing a Zoom for a telehealth visit. It just wouldn't work for him. And, you know, throughout the COVID-19 pandemic, many parents had to juggle working remotely with increased childcare and child education. They became teachers. And the additional stress of online therapy services may just be too difficult for a parent to fit into an already full schedule, especially in a household with multiple children and multiple needs. And Lisa actually has a great example of an interesting telemedicine visit.
There were a few really interesting ones at the height of the pandemic when we were all figuring it out. And I was meeting with one woman for a chronic care follow-up. So nothing that I really needed to be visually seeing her very much for, but she did the visit from her phone and it was dark. And it took me a little while to figure out that she was hiding in her walk-in closet from her children. She had set them up with their online learning, but she couldn't be in the same room with them because they would just constantly be asking her questions. So she was hiding in the closet with the lights off, whispering into the phone to have her blood pressure follow-up visit. That was definitely one of the more interesting ones.
Okay, so next slide. So as we've mentioned, you know, the kinds of things that can be covered in a telemedicine visit. It's just routine follow-up care. Like Lisa was checking on the patient with hypertension. How were her blood pressure readings? Routine monitoring. Acute illnesses that can maybe be diagnosed without having to do a physical exam. So maybe you can do an assessment and determine that, okay, we need to order antibiotics for this individual. We also have lots of routine remote monitoring devices. So pulse oximeters, blood glucose, scales, activity tracking devices. So there's a lot of things that can be utilized by the not only the patient, but also the physician in monitoring. And also the telemedicine can allow for more frequent or prompter interventions. And then, you know, there's always the pain patient that requires a lot of careful monitoring, potentially of the prescription pain medications. And that can be effectively done through telehealth visits, but obviously things like injections and spinal blocks can only be performed in person. And I use an example too. My husband and I were getting ready to go on a bike trip in Oregon, and we stupidly decided to boogie board. Maybe not a smart thing to do when you're 62 years old, and we both got hurt. And so we scheduled a telehealth screening visit with our PA, and she determined how she was going to treat us through the telemedicine. And then she had us come in the next morning for our injections or blocks. So it was very time efficient and very effective for helping us. And, you know, we also always look at the telehealth now as life care planners. So in our life care plans, we may want to consider things that for the pain patients, you know, home management tools such as self massagers, hot cold packs, over the counter topical analgesics, real time we call it, TENS units, and, you know, things like meditation or visualization courses. So there's a lot of different things that can be considered. And then the telehealth or telemental health visits are particularly conducive for a lot of folks. So because it is generally talk therapy and doesn't require that physical contact, it lends itself very well to telemedicine services. And I have the same young woman that has not been able to get the gait training that she needs on her prosthetic leg. She suffered a horrific accident downtown Chicago, and it was a pedestrian versus bus, and she ultimately lost her leg, and she had a lot of PTSD, and so she was scared to death to go back into Chicago, and she has been able to maintain consistent follow-up appointments with her psychologist through telemedicine. And so that's been very effective for her. There's also, while you have local providers that are accepting new patients for the telemental health visits, there's also other platforms such as BetterHelp, Talkspace, Open Path Collective, and Regain, and they can potentially provide counseling and couples counseling services via messaging, chat, phone, or video. And then you also have the MD Live and Doctor on Demand, and they can provide additional psychiatric services in addition to counseling, and that can also be done through telemedicine. So this has been really effective. And this is a big one for us in life care planning community. We all do a lot of pediatric cases, and it's just, I don't think they really know yet the impact of the delay in therapeutic interventions. And for particularly children, I have several cases where right before the pandemic, they were going to be starting intensive therapies. They were going to be doing CBT therapy, and they didn't get that. And there actually are lawsuits now by parents who are saying that the schools breached. Their child didn't get the services that had been intended in the IEP. And, there's some, and I know a lot of people have tried to continue providing OTPT, language speech therapy, throughout the pandemic. And things like, we've spoken with speech therapists, and speech therapists have had very good luck with telehealth, particularly for communication and speech and language. But for swallowing issues and for PT and OT, it's generally not as effective as in clinic visits. So I think it's going to be a while before we really know the impact of the pandemic, and and how are we going to get kids back to where they should be. So as life care planners, we maybe need to think about putting in intensive therapeutic interventions, supplemental therapeutic interventions, which we might not necessarily have done before the pandemic. And I think when I've spoken with therapists, they're still trying to figure out, how do we catch these kids back up? So I think the telemedicine and the teletherapy visits, they were trying to do them, and they were, in some cases, extremely effective. But I think it's going to be a while before we really know, and we need to consider that as life care planners. As far as we continue to face these disruptions and waiting until the schools resume normal operations, that we need to just pay attention to the extent to which we're going to require additional telehealth visits as well as in-person and clinic. Okay. And Lisa, that's back over to you.
So I'm going to talk a little bit about technology. And obviously, if you're here with us attending a virtual conference, you've got the technology to make telehealth happen. And the majority of evaluees that you have do have a smartphone or a computer with adequate internet or cellular service to make a basic telehealth visit work. But there are a surprising number of Americans that don't have that. There was a report by the United States Census Bureau in 2018 called the Computer and Internet Use in the United States report, and they estimate that approximately 10.7% of households in the US, so that's about 35 million households, do not have a computer or a smartphone in their home. They also talk some about connectivity in general. They said that, and in terms of the various disparities, so about 40% of people with a household income less than $25,000 per year either didn't have broadband internet or didn't have a computer in their home. And that was compared to about 5% of people with an income greater than $150,000 a year. Obviously, by state or region, the state with the highest percentage of residents using broadband or with access to broadband internet connections was Washington State, about 85% of their population, and the lowest was Mississippi. About 70% of their residents had access to broadband internet. Age, obviously, the residents that were 35 to 44 years old were most likely to have some form of connectivity, and not surprisingly, over 65 was the least likely. We also cite here a report from the Federal Communications Commission that estimated that approximately 18 million Americans lack access to broadband or high-speed internet. And they were very open with the fact that they think that that's an underestimation. They said that the way that they were doing this poll, that if a broadband service told the FCC that it could offer service to a single customer in a census block, the agency assumed that that service was available throughout that census block. So it was very likely systemically overstating the service. So they went on to estimate that it was likely more between 42 and 162 million, which is a pretty wide range there. So then we get into really, oh, and sorry, one more, was that they also estimated that 1/4 of rural residents and residents in tribal areas have no access to broadband internet. Then what do we do about that? So obviously, if you're building a life care plan to somebody who could have access to broadband internet but doesn't, possibly because of cost, building that into the plan would be step one. Knowing what's available in their area. In a lot of rural areas, there's satellite options, which can be excellent, but can also have some susceptibility to weather. So cloud cover and changes in weather can really interrupt their service. If they have really no other access, cellular hotspots can be very effective. My mom makes cellular hotspots work for her where she lives in the mountains in Virginia. And she runs into issues with the data limits, not necessarily fees, but with one hotspot, she can only get so much data per month. So then she goes to her backup hotspot. So just knowing all of those things ahead of time to build them into a plan for what's available for your evaluee. The government is working on changing this. We know that that may or may not be a fast change, but on August 18th of 2021, the Biden administration announced a series of key investments which total 19 million to strengthen the telehealth services in rural and underserved communities and to expand telehealth innovation and quality nationwide. So obviously we're recognizing how useful that can be and wanting to get it to everyone. The next thing to think about is the hardware itself. For a lot of platforms now, especially while we're able to use pretty much any platform, cell phones are adequate. What needs to be considered sometimes, a life care planner has no say whatsoever really in what platform the provider is going to use. And sometimes the provider themselves don't really have any ability to choose. They may be able to use Zoom if it's all the patient has, but many of the large systems, it's dictated by the health system themselves, what platform is going to be used. So if your evaluee is already receiving telehealth and you're seeing that in the visits and can tell what platform they're using them, obviously they have the ability to get them already. But phones and tablets can be very useful. Laptop computers are great. If it's a desktop computer, you need to be sure that they have a webcam. Those don't always come along. Elderly patients can really benefit from the Amazon Echo Show or similar hardware that they can just do voice activation. If somebody else can help them set it up, it can be really easy to use. And then of course you want to include protective cases or warranties, whatever we can do to help protect that hardware for as long as possible. On the other side, we had written in the HIPAA compliant platforms, but that's really not as applicable at this point now that we know that they're going to continue to allow forward-facing platforms for at least another 7 years. Costs. So obviously costs are a big thing when it comes to life care plans. For the most part, what we've found both in research and in our own cost estimate calls is that they are very comparable to inpatient visits for the most part. When we make our calls right now and we ask about telehealth, almost every office says that it's the same cost. And then payment parity exists in terms of payment parity being that there's a requirement that healthcare providers are reimbursed the same amount for telehealth visits as in-person visits. And as you can see on the slide, 18 states currently have those regulations in place. Another 5 have them in place with caveats, and 27 do not as of August of this year. But I would expect that we're going to see that change in the next few years as telehealth really becomes more prominent. So you might think, if the cost really doesn't change, what does the inclusion in the life care plan have to do with? But at least allowing the option, putting it in as part of, that per the provider or the evaluees, need that telehealth visits can be used, but also it really might change things like frequencies. You might have had somebody who the provider wanted to see them every month, but the evaluee was actually going 4 times a year because they had to travel 3 hours away, or getting a child with a lot of disabilities into the car was a full day of work. So we might be able to provide the visits that the provider wants as opposed to what was actually happening with telehealth.
Thank you, Lisa. So telehealth considerations for the life care planner. I think we've covered a lot of different things, but as Lisa mentioned, you may have somebody that doesn't have internet and they don't have a computer. They may not even have a reliable telephone. So these are the things that you need to look at in your life care plan, is what do you need to provide that will enable the evaluee to access telehealth visits. I thought that was very interesting too, that we're 50-50 on who is considering telemedicine in life care plans. I'd love to talk to you all about finding out why that's the case, because it seems like the majority of my cases, all of them are seeing their providers through some telehealth visits. And as Lisa mentioned too, it really, I never used to, even 2 years ago, I never asked what's the charge for a telemedicine visit. And now we always ask what the charge is. And pretty much straight across the board, we are finding that it is about the same price. And so you want to consider so as we mentioned earlier, sometimes with the telehealth visits, you might be able to schedule more visits than the person would have gone if they were doing in-clinic visits. So you might need to consider that in your life care plan. And then obviously it's very specific to each patient or each evaluee. Once again, you need to look at the hardware that they might require. And it could be something as simple as a better phone, because those visits can be conducted on the phone. Also, do you need to provide protective cases, for children if they're using an iPad? Do you need to provide things that are going to be bulletproof from getting dropped? And then I think Lisa mentioned about telehealth and visits to see providers across state lines. There are some regulations, and we're going to be seeing many more regulatory changes and advances over the next few years as telehealth becomes more of a norm. And there are state-by-state regulations as to what can be prescribed, as well as how many telemedicine visits are going to be reimbursed. And telecommunication uses for the life care planners. I don't know about you all, but I kind of feel like Zoom depositions are here to stay. They are time efficient, they're cost efficient. And sometimes I miss the in-person depositions, but it's also really nice, with the time savings on doing the Zoom depositions. I think those are going to be around for a while, and I'd be curious to hear everybody else's opinion. Remote CMEs, IMEs, as Adam Snyder mentioned in his presentation on Thursday about how to avoid Dauber challenges. There's really no excuse to not request a CME via Zoom. And it's and I've had a great luck on defense cases with the plaintiff attorney agreeing to let me do Zoom meetings. and Zoom CMEs. And I've done a Zoom CME with the evaluee at her work and walking through the warehouse with her phone. And as Adam mentioned, these Zoom CMEs are an extremely, they're very illuminating and give you to see into that person's life or their work. And it's completely different than conducting a CME at an attorney office. And so I think I would highly recommend that on every case you request a Zoom CME with the evaluee or the, the parents or the family members where appropriate. And once again, it goes back to, it saves travel costs, it saves on hotels, it just saves all of that. And then also, in some cases, it makes it easier to use an expert no matter where they live. Being in the Virgin Islands, I always worried that I wouldn't get used as an expert because of the perceived distance from the mainland, which it turned out not to be a problem, but that can be an issue. So anyway, so we are at the end here, and we believe that telemedicine or telehealth is here to stay, that there can be a blended model using the best of in-person as well as remote care that's optimal for all of us and also our evaluees. And I think this is going to be continuing to evolve. And I think Lisa mentioned with the regulations and how things have evolved in her practice, I think we're going to be seeing more and more acceptance of this, better reimbursement. And this is also going to have an impact on how we develop our life care plans.
Thank you so much to both of you. There is one question here, which is, what does the C stand for in CME?
Comprehensive medical evaluation.
Any other questions for Lisa or Carol?
I see two in that. No, okay. Oh, CME is comprehensive medical evaluation, and that's usually what it's called when it's a defense evaluation. So when I'm on the defense side, that's what they've called it. I don't know why it's different. And whereas physicians, when they do an expert evaluation, they're called IME. And I don't know why it's different for a life care planner or nurse, but that's what they've been calling it.
And does Medicare reimburse televisits the same as in person?
Do you know, Lisa?
At least where I live, I actually don't know state by state if that's the case, but yes, they do.
Will this presentation discuss life care planner Zoom visits? I don't.
We are not. I'm not sure, Mary.
I'm going to be talking more about the assessment aspect of it. So I think maybe we can have a discussion about it at the very end in terms of what that means, what that question is involving, because a lot of the stuff that you guys have been talking about and some of the stuff I'll be talking about obviously relates to how a life care planner can do an assessment using telemedicine platforms. Okay.
Right, well, I think that's all the questions at this point. If you want to move on.
All right. So I'm going to be talking about the telehealth assessment best practices. I presented about a year ago at IARP on some of this, and it's been really interesting to see the acceptance of technology, or maybe the unacceptance of technology for some providers. Some new technology features. I've been using Zoom probably for about 4 years, so long before pandemic happened, and there have been a ton of new features that I have found helpful using Zoom particularly, but there are other platforms. We'll also be talking about the ethics. So let's go ahead and just get started here. So let's start with best practices. Assessment best practices is still Plan B. The preferable method is to see somebody face to face. But because of a variety of different things that Lisa and Carol very adroitly presented, the ability to do assessment through the Plan B process is really helpful. And I'll give you an example. I've been working about 4 months out of this year out of Portugal and teaching out of there. And I have a friend of mine who is a physician out of California, and she's licensed in both countries, well, in California and also in Portugal. And so she would travel to Portugal every few months to do some practice there. She flipped it. Now she's living out of Portugal and doing telemedicine in the United States, which I don't know how that works in terms of licensing, but she is now a resident and has completely changed it because telemedicine has become so accessible for her. She also teaches online for physicians. So this is really changing how we as practitioners address some of the tasks that we do in our practice. So let's look at a definition. So assessment, teleassessment is a method of collecting data, information, evidence, etc., using interactive technologies between the evaluator and evaluee who are in different physical locations, using network software security protocols and standardized protocols to protect confidentiality, privacy when distancing recommendations prohibit face-to-face interactions. So there are 4 really important components within this definition. One is interactive technologies. So there's the difference between synchronous and asynchronous. Synchronous is what we're doing right here. It's live. We're all in our respective locations. You're hearing us as we present. Asynchronous is for somebody who may be attending another session and they want to come back and listen to the session that we are recording right now. So it isn't a real time or lifetime. So interactive technologies are those technologies that allow us to interact with somebody, whatever that platform is, whatever the hardware is used within that component. Different physical locations. So we have Carol and Lisa in the same house, but in 2 different rooms. So they're socially distanced. But it could be 2 different rooms in the same house. It could be 2 different houses on the same street, 2 different locations in the same city, in the same region, or in some other part of the world, just that there's a different physical location. And there's the use of network software security protocols. So Lisa talked quite a bit about the allowance that CMS has given us in terms of not enforcing the HIPAA protocols for using or not using platforms that are HIPAA compliant, that have the BAA. That's always my first filter when I'm looking at new technologies. I'm always looking at it through the HIPAA lens, because whether I have 7 years or 7 days, I want to make sure that whatever I'm using has that compliance. And so we'll talk about some of that as we go through this process. And also confidentiality and privacy. That is an ethical standard. That is about 35% of cases involving ethical issues deal specifically with protecting confidentiality and privacy. Anytime you put anything online, there's a higher potential of compromise when it comes to confidentiality and privacy. So we'll talk about some ideas, some techniques as we go through the process that you might be able to use in your life care planning assessment that will help each of these areas in terms of best practices. So pre-assessment is what you do before you start dealing with the face-to-face, start interacting with somebody. And Lisa and Carol talked about the evaluee's level of technological competence. And so I work quite a bit, or I evaluate people that oftentimes are not fluent English speakers. And a lot of times they may not be doing an evaluation directly with me, but they may be showing up at a location that allows them to bridge that technological barrier. That digital divide is technically what it's called. So I've had people who were scheduled at court reporting firms, and that's how they were able to communicate with me. I had a gentleman who is a spinal cord injury patient who was at home, but he was surrounded by his wife who also didn't know the technology, and 3 of his sons who knew the technology very well. And so it's that kind of understanding of where the person is and how they are accessing that interactive platform that you're dealing with. I would say the majority of people that I'm doing some sort of distance evaluation with are accessing that platform with their phones, smartphones. And so doing that pre-assessment is really helpful in terms of getting that information. Who's present? And so I go through a process at the very beginning of my assessment where I do disclosure and informed consent. And part of it is as a rehab counselor, so under my professional code, I have to do that before I even start the assessment. And so I've always used that process as a way to develop rapport with an individual that I'm evaluating. That becomes a lot more problematic because if I'm sitting in my office and they're before me, obviously I could see if there's anybody else present. But if I just have their headshot and I don't know who's around, I have no idea. And are the people that are around able to access the person's information? Are they allowed to access the person's information? So as part of my disclosure and informed consent process, I get to a point where I talk about confidentiality and privilege, meaning that I am not covered under privilege. Our information, our communication is not protected under the law, but I go further in terms of confidentiality. So I go through a process and say, I'm here alone in my location. Are you alone there in your location? And, you know, the most often response I get is yes, except for my dog or my cat or whatever, you know, but that helps understand who is there. A friend of mine just recently went and had COVID testing because she was traveling internationally. And so the COVID test was actually done remotely. And so they had an appointment with the COVID tester where they were accessing through whatever platform. And they had been sent the COVID test. And it was a rapid test. At the meeting, they had to show them their ID, show them the test, and put it before the camera so that they could read the number code on it, actually do the test, and then do the complete seal of the test to be able to put it in the mail and send it out. So different ways of doing things than we have seen in the past are happening. So what is being recorded and by whom? So this has actually been a really important question that I ask in my assessment. And I will always start with me as the person either doing something or not doing something. So traditionally in the past, if somebody was going to record an interview, we got the heads up on it. Not so much anymore. And so what happens is, besides me asking, is anybody else present? I usually say, I just want you to know I'm not recording this in any way. I'm not recording it by screenshot or audioly or video. The only recording I'm doing is with my pen, writing like I would if you were in front of me. I need to confirm that you're not recording this in any way either. And by asking that question, I've actually found people who are recording that I didn't know the recording was going on. One of them was that family with the 3 sons that they were recording the session. And so they stopped recording. Another one was an assessment that I was doing, and it wasn't just me and it was a pediatric case, the child and the parents, but there were also attorneys on both sides present. And when I ask this question, and I make everybody answer it that is in the call, and they all have to indicate who else is present. They all have to indicate whether it's being recorded. And one of the attorneys was recording the session. And I said, I did not know that, and I didn't authorize for the recording. And then the attorneys had a little kind of sidebar, and it was decided that recording was okay. And my policy with that is, if somebody else is going to record, I'm going to record as well. So they're going to be dual recordings. But in that instance, it was really hard to kind of pivot and take care of that. So what I put on the record was, I'm allowing this recording on the stipulation that I get a copy of the recording and any transcript associated with it, and it only be used for this case. And under those conditions, I've never had anybody challenge those conditions. Those are my conditions for recording. They agreed with it and we continued. So even asking the question about recording becomes really important in terms of understanding what's going on. Then does your license allow you to cross state lines, cross country lines if you are doing this from a different country? And so that's a question that you have to answer on your own, depending on where you are. For my specialty, this isn't a question that I need to worry about, but I know that some of you, given your specialties, you do have to worry about it. So as Lisa said, this is something that's quickly changing, and I've seen it continually change even before COVID. And so it's something you need to stay on top of. And is there a backup method of contact? And so I'm in Idaho. I have the highest level of technology that I can have, but actually when I'm on my little island that I was born in the middle of the Atlantic in the Azores with 8,000 people, I have double the capacity technologically than I do in Boise, Idaho. One of my associates says, we communicate so much better when you're gone because the internet connection is a lot better. So I've had issues where I might be doing a video conference with somebody, and all of a sudden their internet goes, whatever goes, and we have a backup way of communication. It's usually the phone. And so establishing that, what is the backup form of communication if you're going to be doing this? So that's kind of the pre-assessment, the things that you need to kind of consider. In terms of the assessment itself, establishing the evaluee's identity. One of my favorite stories was an evaluation of twins back east that were identical twins. And when I was interviewing one of them, he disclosed that when they were in school, he did a lot better academically than his identical twin. So he took the high school competency exam for his brother. So, you know, you hear these stories and they actually do happen. So who is the person? If you've never met this person before, how do you establish that person's identity? Technology tips. So eye alignment. Sometimes people have two screens and the camera might be on one screen, but they may be looking at something else on another screen. So trying to keep the communication as normal as it would be if the person were right in front of you becomes important. Body language also, no rolling of the eyes, just it is a machine before you, but there's a person on the other end. So treat it like you are working with somebody, not just the technology. And then obviously active listening. And sometimes because of the technology itself, it's sometimes difficult to understand things as well as if somebody were in front of you. And so having active listening and understanding of what somebody is saying, I think becomes really important. So paraphrasing is a good technique to use to summarize and repeat back to the person, this is what I heard you say, is this what you mean? Helps to collect information in the assessment process that is helpful. Show me where you are. And so, like I said, the majority of people that I've seen are communicating or accessing the video conferencing platform through some sort of smartphone. That makes it a lot more portable. And so they can show you their home, they can take you to different places, they can take a picture and send it to you. If you can say, hey, can you send me a picture of what you just showed me? That kind of thing might be helpful. Okay. I see a couple of questions coming in, and I want to kind of take a pause right now and see if I could answer any of those. Okay. And I know that people are putting some stuff in the chat and some stuff in the Q&A, so I'll kind of go back and forth. Okay. Okay, got it. Question, will this presentation discuss? Okay, so we've already addressed that. I hadn't seen what was in the chat or the Q&A. So in terms of the assessment, technology tips, I think those are really helpful. One of the clients actually I had within the last year, or evaluee, was somebody who had been a wheelchair repair person for New Motion and could not do that physical work anymore. And so I don't know if you know this, but New Motion has it's now out of New Mexico. I think they centralized it, a call center where they have technicians that help people with wheelchairs, and also their technicians in the field, their service technicians in the field with troubleshooting. And the main form of collecting the information of what's going on with the wheelchair is this. It's their smartphone. And so they're using telemedicine platforms. They're using the platforms we've all been talking about to do even things like a wheelchair repair out in the field and help people on that. So that show me where you are, show me what you mean, allows us to gather information in a way that we haven't had access to before, although it's still limiting because we cannot see everything in our peripheral vision to be able to gather all the information we typically can. Okay. Evaluate fatigue. So this has happened a few times with some of the sessions that I have. It is more fatiguing to be interacting with a video conference platform than it is a lot of times in face-to-face, and everybody's different. So you have to understand where the person is and if this platform is fatiguing for them. And sometimes you have to either build time in for breaks, which I've done in assessments, or build time to have more than one session in terms of an assessment. So what is the person's fatigue factor in terms of the use of technology? So post-assessment, after the assessment, did anything happen during the assessment process that compromised your ability to obtain the data you needed? And so a lot of times right after the assessment, I'm writing those things down because if anything happened, it can impact the validity of the information that you collected during the assessment process. And so writing that down immediately, if somebody else was involved in the process, that they keep on interrupting, even if you asked them not to do that, and did it break down the communication, whatever is going on, did technology break down, and then you had to go from a video conference to a telephone. And so there was a young woman I was evaluating early on. I think it was actually during the shutdown, and she had never really worked with video conferencing, although, and she had traumatic brain injury. She didn't know how to mute and unmute, engage the video, not engage the video. And so we were able to, for the first 10, 15 minutes, do video conferencing, and then she lost it. She changed something and she didn't know how to unchange it, and we had to move it to a telephonic session. So did anything happen? Because that might be something that you need to document in your report. If you're documenting that you need to have another session or you need to have complementary information. So note any impacts of technology, process, or interaction on the assessment process. And do you need to have a follow-up? So there was somebody I was testing. I did the initial interview. As part of the initial interview, we realized that we probably needed to do some vocational testing. So we had a follow-up meeting where we were going to do remote testing, and I'll cover that in a little bit. And when he showed up to that remote meeting, he didn't go to his attorney's office where he was supposed to be. He showed up with his phone. Well, he couldn't do testing on his phone. So he had to set up a third assessment because they had forgotten what I was doing and how I was doing it. So sometimes these processes may take longer than you may have the ability to pivot more readily in a face-to-face situation. Okay, provide copies of signed disclosure, informed consent, checklists, instruments, or other data. So typically what I do is I do the disclosure, informed consent. I do a share screen, just like I'm doing now with this presentation. And we go through it and I sign it, I PDF it, and I send it to them so that they have a copy of it, or I send it to their counsel, or I send it to my retaining counsel who sends it to their counsel. Under my code of ethics, I have to provide them with a copy of it. And so I go through that formal process. Okay. So before I move on to technological changes, let me ask if there are any questions that I need to address. Okay. Yeah.
There's one here about a secure HIPAA compliant connection.
Yep. So that's technology. We're heading into that.
Thank you.
Okay. All right. So let's go ahead and talk about some of the technologies. As I mentioned, I've been using Zoom for about 4 years. Mainly, I got introduced to it because I teach at a couple universities who have used it. One university, and I know Sherry's on the presentation, kind of fought us on the use of Zoom. And we said we're using it anyway because what they wanted us to use was really cumbersome. And when COVID happened, now they're using it. So we've seen a huge transition to the use of Zoom. And there are some aspects of Zoom, some features that didn't exist before that were accelerated because I think of how many people are using it. So some of the technology features, as I said, I always use HIPAA, regardless of the fact that I have 7 years, as my lens when I look at a new technology. One of the reasons I use Google Meet to meet with people is because it has a BAA, and allows me to very inexpensively, $12 a month, as opposed to the HIPAA version of Zoom that's $200 a month, be able to create a platform or use a platform that is relatively, that is HIPAA compliant. So there is a pandemic survey going on right now. The group that is doing the practice survey that happens every 10 years or so in life care planning, we put together a pandemic survey to try to capture what people are doing now in terms of practice. And so I took a quick look at that in terms of the technologies that people are using. Number one technology over the top is video conferencing. And so that is the most commonly described feature. Zoom, of all of them, was the most frequently used or described. A couple people talked about Doxy.me, and I think Lisa or Carol have that on their list. That is free and that is HIPAA compliant. I have not used it, but I did play around with it a little bit. And so I don't know the depth of the features. Some people have used Facebook Portal, which is the Facebook version of the video conferencing, FaceTime, Google Duo, GoToMeeting. GoToMeeting's been around a really long time. I remember doing some webinars for IHARP using GoToMeeting a long time ago. Lifesize, which is not one I was used to, meetings.com, Skype, Teams, WebEx, and the WhatsApp version. And so some of these have, like I said, HIPAA versions. So the Doxy.me, the Zoom, if you have the Zoom HIPAA compliant version, the Google Meet, if you engage the BAA for that, do have some of those. So you would have to individually look at these and see what, how they work for you. One of the things that I like about Zoom, and it's usually an add-on for some of these other video conferencing platforms, is a fairly new feature within the last 12 to 15 months, and is the remote control. And so right now, as I'm sharing my screen, and Dana and I know Dana's in the, and Sherry as well, in our presentation yesterday, if I go to the bar that has my mute, my stop video, all of those things up above, there's something that says remote control. And I could click on that and I could give the control over to any one of you who are presenters with me. And you can take over my mouse and run my PowerPoint. The reason this is helpful is particularly if you're doing some sort of testing where you are bringing up the instrument on your computer, but you're giving the control of the mouse to the person that you're evaluating as you're proctoring them. And so that's a really useful feature that I found in terms of doing assessment. Other things that people were talking about in terms of new technologies. Let me go here. Screen share capabilities. Like I said, find that particularly helpful for doing disclosure and informed consent. I actually find it way easier to do disclosure and informed consent using video conferencing than before. Some people have mentioned that they are doing greater use of electronic signature software such as DocuSign, Hightail, and Adobe Filler files for probably disclosure and informed consent, or some of those forms that you need to have somebody fill out. And so that's one feature that I haven't used in assessments, but I find it quite interesting, and it might be something I'm going to look at for my own practice. So do you have the ability to share your screen? Video and audio minimizing capabilities. And so if I'm doing some sort of remote assessment that the person needs to be working on a particular thing, maybe an instrument that I'm sharing. It's better for me to be able to minimize my video and my audio as they're working to not create distraction. And so does that feature exist with the technology? And we just talked about mouse sharing. I find that really helpful. Okay, this is really fascinating to me. So I don't know how many of you are familiar with McKinsey & Company. They're an international company that does a lot of business consulting. And they did a study once the pandemic started to see how fast companies pivoted and what they pivoted in. And to me, what's most fascinating is how long companies expected that each of these technology adaptations or remote adaptations would take for the company and how long it actually took. So let's look at the first one, increase in remote working and or collaboration. They expected, about a year and a half, they'd roll it out. And, before everybody got online, it actually took on average companies 10.5 days to do that. And you could see that across the board. I mean, most of these estimates are, a year and a half to 2 years that they would estimate it would have taken them to do these services. And most companies were able to pivot within 30 days. So, changing customer needs and expectations. That's a really interesting one because I think many of our needs and expectations, whether they be referral sources, whether they be evaluees, whether they be patients, whatever, have changed in terms of expectations and how we view what's okay to do. And I'll give you an example. One of my neighbors is senior management of one of the utility companies in Idaho. And for her, if you weren't in the office, you weren't working. Well, she and her staff all had to go remote. And she was so amazed at how productive that they were, that their attitude and approach toward productivity has completely changed, and expectations. So they're focused more on the outcome rather than where you do it. So SCORE, the organization that does consulting for the Small Business Administration, indicated that 90% of small businesses digitized in 2020. Virtual meetings and video conferencing, that's what we're seeing in life care planning with some of the responses that we've been talking about and adopting technology. Team collaboration. So I'm involved in several kind of team efforts for research and that kind of thing. And our ability to use technology, whether it's Google Meet for meeting or Google Docs for the sharing of information, has increased dramatically. Shifting to online services, that's what we're doing right here. So this is the second conference, second year running that we're doing training. And it's my understanding that the IARP hit a new high this year in terms of attendance. And I know last year was a new high as well. So shift to online services, how long that's going to go and how much it will go back, we'll see. Employee processing, so collaborative tools like Slack or Google Workspaces. So how people interact within businesses, not necessarily outside of businesses. Customer contacts and relationship management. Now, this is really interesting because until about a year and a half ago, my kids told me that I was really old-fashioned because I used email, and that people don't use email anymore. Well, people are using a lot more email in business, and I think part of it is because of the ability to communicate better that way. I cannot tell you the last time I received a fax. As a matter of fact, I no longer have a fax number. I no longer have a landline, but I keep my phone number. And that's because now we are able to keep our own number without having to give that up if we switch telephone companies. So, but I hardly get any calls because most people are sending me referrals through email. And so the way and the technology that I was even using 2 years ago has changed dramatically, where there's a greater reliance on email. And even if somebody sends me a letter, they're sending it to me as a PDF rather than surface mail. So these systems, this type of communication we're doing and having seems to be about the same, but how we're doing it has changed. How people are communicating with me has changed. I've shut down my website about 8-9 months ago because I'm coming up with it, and people are still finding me because they do Google searches, or I have no idea how people find me, but they do. And so there's other ways that people are accessing professionals, and how we in turn need to look at what we do and is it relevant anymore, because some of the things that we've done and some of the technologies we've used have migrated to something different. So increased productivity and usually lower cost. I'll give you the example of my phone. So my phone was $35 a month, same company. Now I don't have a landline, same number. It works exactly the same way as it did before. I had it forwarded to my cell, and it's less than half than what I used to pay for my landline that I no longer use. Got rid of my fax number because I don't do that anymore. I use things like the app Genius Scan that has gotten way better. If I need to sign a document and all I need to do is scan a couple of pieces of paper, I use Genius Scan. It's a free app. And once you take the scan, it takes a beautiful scan. You could send it password protected to somebody as an email or other remote way of remitting it. So there are technologies out there that are free, that are typically end-to-end protected, such as WhatsApp for communication, such as Proton Mail for remitting encrypted emails that are free or very low cost. Okay, so these are some of my finds. Computer technology and power. That's where it all starts in terms of us understanding what our computer technology and what power we have within that technology. I've upgraded all of my desktop and my laptop within the last year. It's been 8 years, but it's also important for us to know somebody else's technology and power. Security, virtual private network, VPN. And so one of the things that I found when I was first working remotely, like I said, it's been about 4 months, over 3 travel episodes, was that there were some websites that I could not access with just my internet connection. One of them was a GoodRx. There were a couple of government websites in Idaho I couldn't access. The VPN has allowed me to access that, because what it does is shows your computer being tied to a server in a different country, such as the US instead of Portugal or Spain or wherever you are. And it protects that communication that's going on between you and your server. And so the VPN I use is Proton Mail. They came up with their own VPN this summer. It's brand new. And I use the free version, although I use the paid version for the email because I like to send my reports through Proton Mail and have them encrypted. And so a VPN I found to be accessible, easy to use, Connectivity and bandwidth, I've talked about that a little bit. I have worse computer connectivity in Idaho than I do in Portugal. And so understanding that connectivity, and there really is one of the things that has absolutely accentuated what's going on in this country in terms of disparity and the digital divide has been COVID. We particularly saw it with children who were working remote or studying remotely from home that didn't have internet access, that a lot of times the parents were going and parking in the parking lot for a school or a library to be able to access their internet so the kids could do their homework. So this has been a big difference. Paperless cases. You know, I keep my records for 6 years, which is what's required under HIPAA. And when I look at the number of banker boxes that I have in terms of my archives, right around 2016, I started seeing a huge fall. Right now, my files are about this big because I'm typically using some sort of paperless cases. So let me tell you what people are saying that they're using a lot more of in terms of life care planners. Using more things such as Dropbox, shared folders, Microsoft SharePoint, Google Docs, Microsoft Power Platform, any of those. The very first thing I do when I think about using any new technology, I Google HIPAA and then the technology, and I read everything I can about it and contact them to verify what their HIPAA compliance is. Phones, faxes, remote calling and apps. I've talked about that already. What are people using? What are people doing? Any sort of virtual mailbox. I don't know if any of you are using any sort of virtual mailbox. It is, instead of having a PO box or having USPS deliver it to your physical location, it goes to a service such as Earth Class Mail or Traveling Mailbox that scans everything. Both of these, for example, Earth Class Mail and Traveling Mailbox are HIPAA compliant. All of their employees are HIPAA trained, and they will scan things as they come in. You could tell them to open things, they will scan them to you. It's all under the HIPAA compliance, and it's a way to be able to have a mailbox without being there physically, where the mail comes to you wherever you are. Research sources. So this is one of my favorites. A couple years ago, a couple cohorts ago, Sherry and I, when we teach life care planning, we like to do everything very evidence-based. And so when somebody is going to a school, they have access to all of the library resources at that school. But we wanted to teach our students to be able to do research once they were in private practice and didn't have access to the academic databases at their university where they were going. And so we do an assignment where the students have to go to their local library and register if they're not registered, and look at the academic databases that exist at their local library. 100% of the students over the last 2 years have been able to access academic databases through their home computer for their local library to do the kind of research that traditionally has been done when people are at universities, and be able to get these resources for free. So something like EBSCO, where you can do PubMed, PsycInfoLit, that kind of thing, a lot of times is already available to life care planners. The resources are already there. It's a matter of reaching out to your local library and getting access to it. On EBSCO, I would say 80–85% of the articles that you need are already there in PDF. If it's an article you really want and it isn't there, you could usually get it through interlibrary loan through your local library. So that's a big change that I've seen in terms of access and kind of the nomadic revolution for life care planners. That might be helpful. Okay, I'm going to see if there are any questions before I go into the last section here. Yeah, I could put, the question is, do I have a list of the various platforms that I spoke regarding HIPAA compliance? I could put those in the chat at the very end. These are the ones that I'm aware of that are HIPAA compliant. There might be more. I haven't looked at all of these. These are some of the ones, the list that I had were all of the ones that people are using. So you might be using Zoom and it might not be a HIPAA compliant version of Zoom. You really have to research that. The easiest way to do it is to just in a Google search, put Zoom, HIPAA and see what comes up and then contact them. I know that the entry cost point for a HIPAA compliant version of Zoom is $200 a month. Okay. How do I obtain the client's signature? So typically, and I'm assuming that has to do with the disclosure and informed consent. So usually I'm sending those off and most of the time, whether the client or the evaluee, him or herself, or their counsel or my counsel through their counsel are able to get that signature. If they don't sign it, I have the paper trail that I did my ethical responsibility in terms of reviewing it and getting it to them. So, okay. Let's see if there are other questions. Okay. How are we doing on time? Okay.
We have about
go
3
ahead.
minutes left on time.
Okay, I'll go real fast. I didn't put a lot here because I knew I would weave it into the rest of the presentation. Disclosure, informed consent, particularly in an online environment, understanding that it's a different platform and there are aspects of it that are different. The person has to know that there are greater risks with an online assessment. So disclosure, informed consent is number one. Make sure that everybody present understands the risks of using an alternative technology. Find out who's in their respective locations and ask about recording. Report documentation. So any differences, any information you have, put it in your report. So-and-so was present throughout the evaluation and participated appropriately. Who else was there? Testing, competence, make sure that you're competent in the use of any instrument or technology that you are using for testing. This has been a huge, huge change over the last year. A lot of providers like Pearson, any of the test instrument providers have a ton of new training videos of how to do this. And so there's a lot of information out there in terms of the ability to do it. One of the first things I do is test the person in terms of my understanding or my assessment of their use of technology before I make a decision to use a certain test with them. Ability to use the instrument remotely. Can you do it? Can the person do it? Screen share and mouse share capabilities we've already talked about. So those were the main areas I wanted to cover in ethics. And I think we're at time. So let me see if there's any other question that I need to address out there. Okay, any questions before we kind of wrap it up?
I have one question, which is, do you find that attorneys see the credibility of doing assessments virtually versus in person to be comparable?
There's never been a question on it, and I think it's because the psychometric testing companies have also pivoted and have the information of how to do it credibly. There's a training out there on how to do it. Even I think one of the sponsors for the conference is edits for the COP system in terms of how to do it credibly. And so I know that there's even guidelines out there in terms of neuropsychologists. I haven't read a neuropsychological evaluation of somebody who did it remotely, but I know that they have those guidelines out there. So it hasn't been a problem in terms of that being questioned, because the literature is out there to support it. And when you look at the literature and you look at the outcomes, they're comparable. There's no statistical difference. It's one of the things I first researched when I started teaching graduate level assessment at Utah State.
Well, thank you all so much for your presentation. We've learned a lot about this new world that we're in, and it's been really informative.
Thank you, Laura.
Have a great afternoon, everyone.
Thank you.
Bye-bye.